Thank you, Dr. Mahsen. So we we will talk now about surprise during implantation, several situations that we have to lead and to manage. First of all, what we do face to this situation, we have to stop and assess the situation. If you are lucky, we have someone, teacher or coach with our sides, or a voice, friendly voice that direct you what we can do. So we have to understand that in this situation there is a mismatch between capsule behavior. It depends in the patient. Fluidics system, when we have rising IOP in the anterior chamber, we can have this situation and issues with implantation. And at least we have different types of lenses and materials and designs that if we can't understand the mechanism of the IOL, we can have these issues. So there is a lot of kinds of surprise. I choose 5 situations in this because of lack of time with different mental reflex. The first one here, the stuck of the IOL in the incision. So there is 2 situation here. If in this case, what we have to do, as we can see, less than 50% of the is engaged in the incision. So we try to push, but is not moving. So we remove and we re-inject. So don't force, because we can damage the IOL and the incision. So more than 50% of the optic is engaged. We continue, we force in the curve of the board of the lens with the forceps, and we introduce gently the IOL. If we have less than 50% of the optic is engaged, we remove the IOL and we re-inject the IOL with the cartridge. Here, in the second type, we lose a haptic and a part of a lens. And here we have to avoid to keep this IOL in the bag because it's unstable and gives a lot of issues after. 2 methods to remove. Pacman here, we cut 1/3 or 50% of the optic and we remove it. This one is another type to explant when we lose a part of incision, is the twist motion technique to remove the IOL. And so here another, when the surgeon ignore signs, resistance during implantation, we can damage the cartridge and lose the IOL. So we have to add OVD in the cartridge to avoid this situation. Here the cannonball, the IOL during the speed of the injection is very high, and the IOL can damage the capsule. So here we have to stabilize the bag by a PCC here and if we are able to stabilize the bag, we can leave the IOL in the wheel of the remaining capsule. If we don't, we have to remove and make and implant with 3 pieces IOL. Here we are trying to stabilize the IOL by a PCC, posterior capsular excess, and we leave stabilize the bag. Here, if we don't stabilize the bag, the tear is extended and we can lose, we drop the lens down. So here, Dr. Killen is trying to remove OVD behind the IOL, and he missed the stabilization of the toric lens, and then he are stabilizing the IOL under fluidics. So we have to check the alignment of the toric IOL at the end. Here the lens is in the cavity. Fishing the lens is prohibited because we can damage the retina. So the checklist for the implantation: before injection, we have to have a very good knowledge about IOL, what we use. We have to lubricate the cartridge, and the incision must be large enough to introduce the IOL. During the injection, we have to center the tip, slow delivery to avoid cannonball, and watch the leading haptic. It can be traumatic for the capsule. After injection, we have do both haptic behind the capsule, remove OVD through behind the IOL, and really we have to add OVD, not energy, never push a dry cartridge. And at the list, calmness surgeon wins the surprise, and we can scan this QR code to have this presentation in your phone. Thank you.
Thank you for that nice presentation, Dr. Walid.